Good morning, everyone. Welcome again to the second day of our 2021 Gastroenterology and Hepatology Board Review course. Today's course is going to be focused on pancreatic and biliary disorders, followed by liver disease. And these two categories will compromise 30% of your board course. This is our disclosure slide, as well as the comment that we are offering both CME and MOC points for this course. You will have more information tomorrow afternoon on how to claim credit for CME and MOC. And if you have any questions, you can reach out to the CME staff as well. And finally, we are going to be using Poll Everywhere today to answer the polling questions. And as a reminder, it seems to work better if you actually download the Poll EV app to your phone. But the ways you can log in are to go to pollev.com/gastro 2021, and you can access that on your phone, a laptop, or any other mobile device. If not, you can also text gastro 2021 to 22333, and you'll also be able to join that way. But we're finding that it's easier if you download the pollev.com app. So we'll just start with some practice questions just to make sure that everybody's been able to download the app and are able to use it. So again, go to pollev.com/gastro 2021. And the first question we'll start off with is, what is your favorite season of the year? Spring, summer, fall, or winter? Let's see that 3 people have answered. Great. So let's see the answer. Great. Most people enjoy the fall. Okay. So we are going to start off the first session of the day with disorders of the gallbladder, bile ducts, and pancreas. I'm going to hand it off to our moderator now, Dr. Monique Barakat, who's one of our therapeutic endoscopists at Stanford. Thank you very much, Monique.
Thank you, Dr. Raju. It's a pleasure to be part of this session, and I'm joined by some of my esteemed colleagues in therapeutic endoscopy who have expertise in pancreaticobiliary disorders at Stanford. As part of the session, I wanted to introduce the panelists, and those will be running through some of the practice board review questions. So we have Dr. Banerjee, who is Director of Endoscopy at Stanford and has extensive research in pancreaticobiliary disorders and therapeutic endoscopy approaches in general, and also has served in leadership roles in the ASGE. Dr. Eldika, a therapeutic endoscopist with a broad range of endoscopic expertise and exciting research focused on enhanced US-based imaging and interventional endoscopy. And we'll be joined by Dr. Walter Park, a pancreatologist whose career is focused on investigation, teaching, and care of patients with pancreatic disorders. And he serves as medical director of the Pancreas Clinic at Stanford. And then I'm Monique Barakat. I'm a therapeutic endoscopist who focuses on pediatric and adult pancreaticobiliary disorders and overall therapeutic endoscopy management of these patients. So we will begin. We've worked out the bugs in the question system with our initial session. And so we'll begin with the questions for our session here. I'm going to be reading the questions just as an introduction, and then we'll go on to the answer selections. And then we'll have an expert, we'll select an expert to review the answer choices with you. So first question, you're evaluating a 55-year-old woman with a long-standing history of elevated liver enzymes, ALT 57, AST 46. An extensive serologic workup was negative, and imaging was notable for an echogenic and enlarged liver with patent hepatic and portal veins. The patient does not have a history of alcohol excess. Over the course of the evaluation, you ordered a liver biopsy that revealed histologic features typical of non-alcoholic steatohepatitis with stage 1 fibrosis.
I think we may have the wrong.
I don't think these are the right questions.
Yeah, we need to move to our session.
Yeah, I think this is for the liver session, Sonia.
Otherwise, we're going to get the help of DP.
Okay, let's switch that over.
To slide 23.
We are highly specialized here at Stanford, and I think we may struggle as our pancreaticobiliary specialists with these liver-focused questions.
We're switching right over. Just 1 second, please.
Thank you.
Sorry
There you
about
go.
Okay. This looks more like our territory. A 24-year-old woman is referred to you for a second opinion regarding abnormal imaging findings and recurrent low-grade fevers. Ultrasound done to evaluate the right upper quadrant vein revealed dilation of the common bile duct. ERCP is recommended and revealed multiple dilations of the extrahepatic biliary tree, as shown below. Her medical history is otherwise significant for hypothyroidism. Liver enzymes were assessed and are normal. Okay, next slide. Which of the following is the next best step in management? Colonoscopy with biopsies, A. Liver biopsy, B. Surgical referral for cholecystectomy and hepaticojejunostomy, C. ERCP with brushings and stenting, D. Referral to liver transplantation, E. We'll give you a few seconds to answer the question. Go back to the question stem so you can review that. Okay. Can we go ahead and move on to the answers? Okay, looks like 100% of respondents got this correct. Surgical referral for cholecystectomy and hepaticojejunostomy, C. Dr. Banerjee, would you like to walk us through this question?
Yeah, sure. But it looks like I'm preaching to the choir here with the 100% response rate. I think our participants know exactly what's going on here. So if you flip back to the image, the previous slide, Sonia. So that's an ERCP, obviously. You can see the backbone, the duodenoscope, and you're seeing a bile duct that is very dilated to almost cystic proportions, and there are all these bulgy areas in both the extra and the intrahepatic ducts. So anytime you see a dilated bile duct, the first differential is, is an obstructive process going on? So is there distal stricture or distal stone? They're not really showing us the distal part of the bile duct here. So I guess they want to take that off the equation. They're focusing more on the middle and upper third of the bile duct and the intrahepatic biliary tree, which do show lots of areas of cystic dilation. So I think they don't want you to be thinking along the obstructive line. And then you have to look at the other main reason for bile duct dilation in the absence of obstruction is the whole genre of bile duct cysts. And so then we look at the questions, right? Are they trying to fool us with any of these? Colonoscopy biopsies, I guess they're trying to nudge you towards primary sclerosing cholangitis as a possible diagnosis. That's the only kind of bile duct disease which has a kind of colonic correlate. So that's off the table. Liver biopsy implies more of a hepatic process, although sometimes you can diagnose TSC, for instance, with this as well. So that's not the correct answer either. You all pick C, which is the correct answer. D, brushings and stenting. If there's an obstructed portion in this bile duct, then yes, you would brush it. As you know, as you all collectively diagnosis of the bile duct cyst, there is an association with bile duct cancer as well, as you know. So in that scenario, certainly you might want to brush and stent if there were an obstruction, but that's not the correct answer here because there's no implied stricture. And lastly, referral to liver transplantation. That is an option in some kinds of cysts, which we can discuss going forwards. Can we switch to the next slide? And the next one again. Oh, I've got a different slide set clearly. All right, so I have a different slide set here from the one that's being displayed. So my slide, there's actually a sketch of all the different kinds of biliary cysts, but just to run through them, although I don't have an image to show you. Type 1 is the commonest type, accounting for 50 to 85% of the cysts. And this is cystic or fusiform dilation of the entire extrahepatic bile duct. And this is the commonest type. Type 2 is a true diverticulum of the bile duct, where you just have a little sac-like structure sticking out from the bile duct. Type 3 is also called a cholebecocele, and this is just a cystic dilation of the intraduodenal bile duct. Type 4, which is what we're seeing out here, There are multiple cysts involving both the extrahepatic and the intrahepatic bile ducts, and type 4 can be both intra and extrahepatic or just the extrahepatic. That gives you 4A and 4B, the two subtypes. And lastly, type 5, you have multiple intrahepatic cysts. So the management for type 2, which is the sac on the edge of the diverticulum from the bile duct, that's easy. That's a surgical excision of that cyst. For type 3 of the choledococele, where it's just the intraduodenal bile duct that's involved, the management is usually endoscopic, either big sphincterotomy with deroofing of the cyst or endoscopic excision. That leaves us with type 1 and type 4. For these, the management is complete excision with Roux-en-Y hepaticojejunostomy. And then the lesion to hepatic transplant is for type 5, because that's predominantly intrahepatic cysts, the so-called Carolese disease. There's not a lot of options there endoscopically. So typically, these patients wind up getting recurrent cholangitis, which is managed medically. If the disease is predominant in the left lobe, left hepatectomy is an option. If it's diffuse disease, then we just manage the patients medically until a point comes where they might need liver transplantation. I guess that sums up all of the liver cysts.
Thank you, Dr. Banerjee. That was a very comprehensive review of liver cysts and choledochal malformations. I'm not sure why that slide didn't appear, but we were supposed to have a diagram, and perhaps we can get that to the attendees at some point or through our leadership. Next slide. The next question, a 26-year-old man is admitted to the hospital for recurrent fevers, rigors, and jaundice. He is a recent immigrant from Vietnam. His physical exam is significant for a temperature of 39 degrees Celsius, scleral icterus, and right upper quadrant tenderness. His labs show a T bilirubin, a total bilirubin of 4.9, bilirubin 4.1, direct bilirubin of 4.1, alkaline phosphatase 428, ALT 95, and AST 106. He started on IV antibiotics. An abdominal ultrasound shows a dilated intra and extrahepatic ducts. An ERCP is done, and multiple stones are extracted. The patient is most likely to have which of the following? A, brown pigmented stones, B, black pigmented stones, C, cholesterol stones, D, PSC, or E, gangrenous cholecystitis. We'll give about 30 seconds, going back to the question, we'll give about 30 seconds for the responses, and then we'll move on to explanations and review. Okay, we'll go ahead and go on to see what the responses were. Next slide, next slide. Okay, so we have a split between brown pigmented stones and black pigmented stones. May I turn it over to you again, Dr. Banerjee, to discuss these responses?
Wow,
you're not preaching to the choir
anymore. Cup of coffee. All right. So the correct answer, folks, unfortunately, is brown pigmented stones. And I guess the tip-offs here as to what the diagnosis is, firstly, the geography. This is somebody from the Far East. Secondly, there are multiple dilated intra and extrahepatic ducts with downstream strictures. You're given the information that multiple stones are present. They don't quite say these stones when the intrahepatic bile ducts are not, but I think that's implied. And of course, the setting of cholangitis. In that scenario, most of these stones that occur in the setting of infection tend to be brown pigmented stones. Black stones occur with hemolysis, and cholesterol stones, of course, are formed in the gallbladder. But in the diagnosis here they're pushing it towards is oriental cholangiohepatitis or recurrent pyogenic cholangitis, different names, but the same condition. And this is basically a disease of unclear etiology, which occurs predominantly in people who have lived or are living in the Far East. Based on epidemiology, it's thought that since most of these people come from areas that are endemic And for worm infestations, it's thought that this is related to worm disease with secondary bacterial infection. And these can be primarily hepatic kind of worms like liver flukes, but also Ascaris lumbricoides. The roundworm has been implicated in the etiology of this particular disease. It tends to affect the left lobe more than the right lobe, which offers us a kind of surgical option in a very severe disease where endoscopic management is failing and interventional radiology can't offer options in extraction of some of these stones, and the patient is getting recurrent attacks of cholangitis that are suboptimally treated. There's an option of just doing a left hepatectomy. And that's not necessarily a bad thing, because with time, often the left liver lobe becomes very atrophic and scarred down and does not really contribute very much to the hepatic function. So in that scenario, just getting the left lobe of the liver out offers you a therapeutic option where endoscopic options and interventional radiology fail. Samir, any other comments on, that you might have to offer?
I agree. I mean, this is, in this question, the ERCP has shown that there are fill-in defects in the left side of the biliary tree, which is, as you mentioned, most commonly involved in this entity in stone formation. Etiology, as you mentioned, parasitic infection, bacterial infection from Southeast Asia.
Yeah, it's not quite clear why the left lobe gets involved more, but the thinking has been maybe anatomical. The left lobe, the left ducts feeding the left lobe connected to a slightly more acute angle, and the strained theories that may impair flow a little more and therefore lead to.
There is a talk about
stasis.
About increased risk of cholangiocarcinoma in these patients. So it's not very clear, risk, but it's something to keep an eye on when you have strictures and recurrent infections of that area from oriental cholangitis.
Yeah, certainly. Those are very important points. Thank you for the discussion. Looks like we now have a slide up regarding choledocholithiasis that's reviewing.
I think she may have slipped the slide with the question. Can you back up there, Sonia?
Yeah, I think we need to go back one. Can we go back one slide?
Yeah, let's, we're going to switch the slide deck. There.
Okay, thank you. Certainly some important points raised about recurrent infections, cholangiocarcinoma risk, and also subtypes of stones, which are a favorite for the boards, asking different questions about colors and types of stones.
Sonia, the next slide. I think we're done with this one.
There was no other slide, so let's just, if we can move on to the next question. Thank you.
Yeah, we can go to the next question. That's fine. Thank you. All right, so we have a 58-year-old man presents for evaluation of right upper quadrant pain, which started 8 hours prior to admission. He's hemodynamically stable and afebrile, and his lab evaluation is as follows: AST 93, ALT 77, alkaline phosphatase 132, bilirubin 4.8, leukocytes 5.6. Abdominal ultrasound is done and reveals cholelithiasis and a common bile duct, which measures 9 millimeters. Next slide. What is the next best step in management of this patient? A, cholecystectomy, B, MRCP, C, ERCP with sphincterotomy, D, ERCP with sphincterotomy followed by cholecystectomy, E, cholecystectomy with intraoperative cholangiogram. We'll go back to the question stem. So you can review that, and we'll give about 20 to 30 seconds for you to respond. Okay, we'll move on to the answers, the responses. Okay, we have another split here. No more preaching to the choir. Dr. Banerjee, would you like to take the lead in discussing this question as well? And we will distribute it to other panelists. We're just starting off with biliary questions here.
Sure. Happy to. So I guess this question gets to the heart of how do you triage a patient who clearly has gallstone disease, right? Biliary colic is triggered by passage of a stone from the gallbladder to the bile duct, and once the stone is there, it can cause obstruction, but sometimes, as you know, when the stone obstructs, intrabiliary pressures rise and the stone is sometimes expelled. And so do you do an ERCP in this patient and put him at risk of pancreatitis? Or do you send the patient directly to cholecystectomy? I think that's what they're trying to tease out here. The ASG a while ago came out with risk stratification criteria, which help guide whether or not you should perform a pre-operative ERCP. And essentially what they came out of the different kinds of predictors, the very strong predictors that a bile duct stone was present, and ergo you should be performing a pre-operative ERCP, include a bilirubin greater than 4 milligrams per deciliter, 1, ascending cholangitis, which implies an obstructive process, 2, and obviously, if you actually saw a bile duct stone on imaging that was done before the patient even got to you, whether that's an ultrasound or an MRCP or whatever. So if you have that data that clearly shows a stone, then it's justifiable to go ahead and do an ERCP sphincterotomy, get the stone out, and then send the patient for cholecystectomy. So these are the very strong predictors. You then have what are called strong predictors. And these include basically either dilated column bile duct, which this patient has, I can't remember what his was, 9 millimeters. Anything over 6 is considered a dilation. So that would imply he's got at least one strong predictor there, and an elevation in bilirubin that's modest. So not quite the 4 milligram threshold, but something below that. So a single very strong predictor would buy you an ERCP. If it's just a strong predictor, namely bile duct dilation with a less elevation in bilirubin, then you need to have both of those predictors in place to buy yourself an ERCP prior to your cholecystectomy. Lesser predictors, or the so-called moderate predictors, include some abnormality in liver tests, not achieving thresholds we already talked about, gallstone pancreatitis, or an older age. And so with those lesser predictors, you really want to get some kind of pre-ERCP imaging. And so that's where the MRCP option comes up. But there's some suspicion that a stone disease was involved here because the patient has either gallstone pancreatitis, some mild elevation of LFTs, and in that kind of scenario, yes, you would get an MRCP. So in this scenario, the patient really has all these very strong predictors. The correct answer would be an ERCP with sphincterotomy followed by cholecystectomy. I'll open up to comments from Samer as well.
Yes, I mean, for the sake of the board, I think this is something that you need to be aware of and base your answer based on these recommendations. These predictors, they're not perfect though. And, in clinical practice, a lot of time, even with, very strong, it's obvious you need to do an ERCP, but for strong predictors, a lot of times we go and do the ERCP and the stone has already passed. So there are some studies that have shown, for these like strong predictors, if you do endoscopic ultrasound prior to the ERCP, most times you won't find a stone. So we have a tendency in clinical practice to really utilize endoscopic ultrasound before the ERCP. Now, if it's intermediate and you don't want to sedate the patient, then an MRCP is the way to go. To make sure there are no stones in the biliary tree before sending the patient to surgery. Just be aware of the fact that MRCPs are very sensitive for biliary stones, but for small bile duct stone in the distal bile duct, it's not as sensitive as endoscopic ultrasound. So it can miss these small stones in distal biliary tree. But for the sake of the board, I think you have to stick with these predictors that we use to determine if we can just go ahead and do the ERCP for cholecystectomy.
Thank you for that, those highlights, and I think that really represents the divide that we're seeing in some of the responses to the question is that sometimes the clinical practice diverges a little bit from exactly what the board's response would be, or the correct answer on a board's question. So we do have a question in the question and answer box, and that has to do with why different stones are different colors, and what the composition suggests. Why are stones different colors? So I will take a first answer and then open it up to our panelists as well to contribute and give their thoughts. So for black stones, there are three main colors of stones, as Dr. Banerjee alluded to: black stones, yellow stones, and brown stones. For black stones, they're more calcium bilirubinate and complexes of calcium, copper, and some mucin glycoproteins, and that's thought to contribute to more the black color of those stones, often seen in situations of hemolysis and breakdown products. Yellow stones tend to be composed more of cholesterol, thus contributing the yellow color, and they tend to form in the gallbladder and then drop from the gallbladder down. Brown stones are often seen, as in our question that we had in this board review, in the setting of infection. And those are kind of a mix, as you might expect: calcium salts of unconjugated bilirubin, small amounts of cholesterol, and probably some protein. Even breakdown products in the setting of infection are thought to contribute to the brown color. Any other comments from our panelists about stones and colors?
No, I think that was a very complete explanation, Monique. Nothing to add.
Thank you. Okay. We will move on to our next question then. Can we go to the next slide? An 18-year-old woman presents for further evaluation of jaundice. Her past medical history is notable for 2 prior episodes of idiopathic pancreatitis. Her AST is 50, ALT is 60, alkaline phosphatase is 140, bilirubin 4, and lipase is 150. On examination, her sclerae are icteric. She has non-tender depalpation over her abdomen. A right upper quadrant ultrasound is obtained, and extra and intrahepatic ductal dilation are noted. An MRI MRCP is pursued and shows abrupt tapering of the common bile duct within the pancreas head, as well as delayed pancreatic enhancement with a thin rim of peripheral enhancement as seen here. Her common bile duct stricture is most likely secondary to which underlying condition? A, cholangiocarcinoma, B, pancreatic adenocarcinoma, C, an ampullary adenoma, D, IgG4 disease, E, PSC, or F, chronic pancreatitis. If we can go back to the question so they can see the image. Okay, perfect. So we'll go ahead and give, again, some time for responses, and then we'll see what the responses have come in. Okay, we'll move on to the answers. So slide forward again, and view responses. We have a bit of a split here between pancreatic adenocarcinoma and IgG4 disease. Dr. Eldika, would you like to discuss the responses to this question?
Absolutely. So the first answer is cholangiocarcinoma. I mean, apparently we can have cholangiocarcinoma involved in the distal part of the bile duct, causing biliary obstruction and dilation of the biliary tree, but that won't explain the findings in the pancreas, where you have this inflammation and enlargement of the pancreas with the other features that I'll talk about a little bit later. Pancreatic adenocarcinoma causing biliary obstruction, that's something to keep in mind, always in differential. This is a young patient, so unlikely that she has pancreatic adenocarcinoma and obstructing the bile duct. And we don't see also the features that we see in the pancreas to that. If you have a pancreatic head mass from pancreatic adenocarcinoma, you should see also obstruction of the pancreatic duct with dilation of the upstream pancreatic duct and also atrophy of the pancreatic parenchyma. You don't see that in this case. You see enlarged pancreas. And pylori adenoma can cause obstruction of the bile duct and can also cause obstruction of the pancreatic duct and can be a reason for pancreatitis as well. It's a possibility, but it doesn't explain, the imaging and finding in the pancreas. The correct answer is IgG4 related disease. Why it is the correct answer is because of the typical finding on MRI. If you want to go back to the previous, to the question, show the image. So you can see the enlargement of the pancreas, sausage shape appearance of the pancreas. A typical also finding of delayed pancreatic enhancement and also this enhanced rim on MRI that can show as low attenuation on CT scan, but on MRI here you have the hyper enhancement. This is consistent with autoimmune pancreatitis, and the inflammation in the head of the pancreas could be responsible for the obstruction of the bile duct with dilation of the bile duct and elevation of liver enzymes. This could be just because of the inflammatory process in the head of the pancreas versus involvement of the bile duct related to IgG4 disease. Here, you have to stop here and look at the criteria for type 1 autoimmune pancreatitis, and usually when the bile duct is involved, to consider it as other organ involvement, the stricture has to be in the proximal bile duct. Distally, it could be related to that, or it could be just from the inflammatory process involving the head of the pancreas. So the right answer is IgG4 disease. When you're looking at this picture, you also want to make sure that you don't have any retroperitoneal fibrosis around the aorta, and you look at also the lower cuts to see if there are any liver lesions as part of IgG4 related disease. Let's go back to the answers. This is not PSC. It's a one stricture distally, very unlikely for PSC to have a single stricture in the distal part of the bile duct. This is very rare. This is not a picture of chronic pancreatitis. We don't see any dilated pancreatic duct or features of ductal changes that we see with chronic pancreatitis. In this case, again, the imaging is more typical for autoimmune pancreatitis in this case. Walter,
I agree. I
anything
think our participants chose the top two possibilities in the scenario, right? So you have a patient with a couple of attacks of pancreatitis and now with obstructive jaundice and a distal stricture. And so the top two possibilities here truly are IgG4 disease and pancreas adenocarcinoma. The others don't usually apply here. And I think what makes it IgG4 disease is just the very broad hint they've given you on the imaging. So if you see a diffuse enlargement of the pancreas with delayed enhancement, that is highly suggestive of IgG4 disease. And then they even go on to give you the finding of rim enhancement, which is again a very classic finding in IgG4 disease. You should not be seeing all of those things in pancreas cancer.
Well, Walter, what do you think if you had the option to answer that, type 1 autoimmune pancreatitis or type 2 autoimmune pancreatitis, can you distinguish based on this data between the two?
No, you can't distinguish just by that, but I think to echo what you and Subhas already said, this is a relatively straightforward question of look at the picture and what is it, right? And this is a classic finding of autoimmune pancreatitis. And an 18-year-old is probably, in fact, statistically not IgG4, it's probably the type 2 variant. And so that's the one oddity of this potential question stem, is that because most of the board review questions are trying to be classic epidemiologic demographic. So perhaps on the boards, it would be like a 60-year-old man who presents with this finding, and you're concerned about adenocarcinoma, where adenocarcinoma also is going to be epidemiologically more likely, whereas you're probably not going to see a cholangio or a pancreatic adeno or ampullary in an 18-year-old. It's pretty unlikely. But without overthinking it, this is really just about look at this picture and you recognize that this is a classic finding of autoimmune pancreatitis.
Yes, certainly. These are all such important points. And we have selected the career and a focus in pancreaticobiliary disorders. And so we like to go through these thought experiments just to emphasize for the attendees, focusing on what's most likely in the setting of the question stem is key for board review. But we're excited about the topic and enjoy discussing all possible alternatives. Next question.
Monique, I think we have a question from the audience.
Oh, we do. Can you clinch diagnosis on clinical history and imaging alone? I assume you would still biopsy. And I think this is regarding autoimmune pancreatitis.
Yes. So the pathognomonic, the only pathognomonic criteria, or the best one is based on the histologic diagnosis. So if you can get that through EUS biopsy, that will help you if you get the typical features of autoimmune pancreatitis. But a lot of time in clinical practice, you have to really rule out other causes and depend on the clinical and imaging criteria for that, as well as serologic criteria.
The original criteria were done in the context where biopsy wasn't of high yield. So the system was really a clinical and imaging system. So yes, if you had the right clinical history in the imaging, and in the setting of IgG4 disease, supporting evidence with serum elevated IgG4s, you could make a presumptive diagnosis and treat. IDCP or type 2 autoimmune pancreatitis is a little bit more challenging because it's going to be non-IgG4 disease, but you would have the classic imaging. It would be reasonable to go ahead and treat, but particularly in the younger individuals, it's probably safer. In the older individuals, if you do empirically treat, you do have the requirement to follow up, with 2 to 3 week follow up to make sure that there is an immediate or a clear response to steroids if you do proceed with that. I will say that I think with core biopsy needles generating more yield, I think there's a general trend to doing more biopsies now of the pancreas because we are getting better yields. And when you work closely with your pathologist and let them know what exactly you're looking for, it can be beneficial, but I don't think it's standard or required.
Yeah, that makes a lot of sense. And this patient is kind of on the brink of the pediatric population in which obtaining biopsies is current standard of care in patients who present this way. So there's a little bit of divergence between pediatric and adult practice. Rather than doing a trial of steroids, oftentimes biopsies are obtained. So we'll move on to our next question if there are no other questions. A 25-year-old male presents to the emergency department with severe epigastric pain and mild elevations in lipase, 3 times the upper limit of normal, diagnostic of acute pancreatitis. The patient describes multiple episodes of pain and associated pancreas enzyme elevation since early childhood that generally respond to brief hospitalizations and conservative treatment, including intravenous fluids and IV analgesics. CT imaging reveals parenchymal calcification seen throughout the pancreas. Further history discloses 2 relatives with similar pain attacks. Which of the following gene mutations is most likely to be associated with the cause of the recurrent pancreatitis in this patient? BRCA1, PRSS1, SPINK1, Delta 5F08, PRSS2. We'll give some time for responses and discuss the answer. Okay, we'll move on to the answers selected. So we have a split between B and C, BRSS1 and SPINK1. Dr. Aldika, would you like to discuss this question?
Sure. So the first answer, BRCA1, is not associated with increased risk of pancreatitis, but it's associated with increased risk of pancreatic cancer. PRSS1 mutation is responsible for hereditary pancreatitis, and it is an autosomal dominant disease with high penetrance. And with the clinical presentation of this patient, young age, multiple episodes, and leading to chronic pancreatitis and calcification at the age of 25, this is the right answer, PRSS1 mutation. In this mutation, what happens with this mutation is you get a gain of function. And instead for trypsinogen to stay inactivated and doesn't convert to trypsin until it's supposed to digest the food, it gets prematurely activated and then start injuring the pancreas and causing a cascade of inflammatory process. SPINK1 is a cause of pancreatitis, recurrent pancreatitis, but it's an autosomal recessive. In its heterogeneous state, it doesn't cause acute pancreatitis, but it can be responsible with other mutations to cause recurrent acute pancreatitis and eventually chronic pancreatitis. It's not as common as a genetic cause of pancreatitis compared to PRSS1. Delta 5F08 is one of the variants seen in cystic fibrosis gene that can be a cause of pancreatitis, usually with the combination of other mutations like SPINK1 or other environmental factors, or as part of the full-blown cystic fibrosis mutation disease. PRSS2 is a mutation involving the anion trypsinogen, and it's believed to be protective against pancreatitis, so it's not the correct answer. So the correct answer for this is PRSS1, hereditary pancreatitis, answer B.
Thank you for reviewing that, Dr. Aldika. This is kind of a classic boards question, so it's nice to make sure that we cover it in detail, and you've covered it very nicely. Next question. Cholecystokinin is a hormone secreted from the enterocytes of the small intestine in response to a meal. Which one of the pancreas cells secrete zymogen proteins in pancreas fluid in response to cholecystokinin? Okay. So I'll open this up to Dr. Park. Oh, first we'll get your answers, sorry. Let's go ahead and see the responses. We'll give about 20 seconds. Okay, let's go on and see responses. All right, so we have another split, acinar cells, duct cells, and G cells. We'll go ahead and have Dr. Park discuss this one, if that's okay.
Sure. This is, I think this is a question of whether you know it or you don't. It's not challenging. There's no real kind of gamesmanship on the question. First question is, which of these cells are in the pancreas? So acinar and duct cells are, stellate cells can be, Panth and G cells are not. Sometimes with G cells, you can see some, but generally for board review, Panth and G cells are not pancreas cells or intestinal cells. So you can remove those. So then the question is, just to what extent do you know whether the physiology here and And the correct answer is A, acinar cells. CCK stimulates acinar cells to secrete out the pancreatic enzymes. Duct cells release bicarbonate in response to secretin. Stellate cells don't, as far as we know, physiologically respond to either of these two, but they're involved and seen in pancreas cancer and chronic pancreatitis. I think that's it.
Thank you, Dr. Park. Again, this is, as you said, you know it or you don't. It seems like most of our respondents know it. Next question. Okay, a 25-year-old woman with abdominal pain undergoes a CT scan in the emergency room. An incidental 2.5 centimeter pancreas cyst is seen. There is no history of pancreatitis and no family history of pancreas cancer. EUS reveals a central stellate scar and multiple small cysts in a honeycomb appearance. Aspiration of the cyst is negative for malignancy with low CEA level and high glycogen levels. What is the next best step in management? Observation, surgical resection, endoscopic ablation, ERCP with spyglass, repeat EUS in 1 year. We'll give about 30 seconds, 20 to 30 seconds for responding. Okay, can we go on to see the responses? Great. So observation, surgical resection, and repeat EUS in 1 year were all suggested as steps in management. Dr. Park, would you like to discuss which one's correct and how you address this question?
So this is a question about what do you know about pancreatic cysts, and specifically, what do you know about the cardinal textbook board review features or should know? And again, you know, one of the tensions we kind of talk about is what do you do in clinical practice versus what is the board review answer here? Now, if you go back to the question stem, if you focus on the board's review aspects, they're giving you the clues in the last 2 sentences, right? They're giving you the key descriptors of what this cyst type would be, particularly the central stellate scar, the small cyst, and a honeycomb appearance. These are all kind of those key words. The low CEA levels, interestingly, include high glycogen because glycogen is not something we typically measure, but it's trying to give you insight into the pathogenesis of this particular cyst type. And in this case, what we're talking about is a serous cyst adenoma, which is a common pancreatic cyst that's seen. It's considered to have no malignant potential, such that the correct answer is observation A, in that you don't necessarily need to do any type of surveillance in the future, and you can leave it alone. Now, so that's kind of the board review question in terms of what you do with the question here is, can you appropriately identify what cyst type this is and what then is the management? And if you appropriately diagnose this as a serous cyst adenoma, the answer is observation. Now, you know, so that's the answer. In terms of the surgical resection, the repeat EUS in 1 year, you could make an argument that it truly wasn't an incidental cyst if the patient presented with abdominal pain. We're probably thinking too deeply now and not sticking to the simple boards review issue. And that would be one indication for doing a surgical resection on a benign cyst, not because of a concern for cancer, but be due to a concern of, or the thought process being that the cyst has grown to a point of creating a mass effect leading to pain, and therefore the indication is pain alleviation. Finally, the repeat EUS in 1 year, again, these are not the correct answers, but you might see this in clinical practice, particularly if you're concerned that maybe the biopsy or the cytology, you're not sure of it, you can't rely on the classical imaging. The differential would be a cystic neuroendocrine tumor. 25-year-old, you'd be worried about a solid pseudopapillary neoplasm. And so you'd think, well, gee, is this really a serous cystadenoma? So I empathize with the B and E answers, but for the sake of the board review, A is the appropriate answer. And these are the, again, this kind of, you can see here in the lower left corner in gross pathology, that central stellate scar. The histological appearance of these cysts is that they're not cuboidal, I'm sorry, they're not columnar, they're cuboidal glycogen-rich cells, which is kind of evident on the H&E slide there. The CT scan on the bottom right shows that central stellate scar. The top left is the endoscopic ultrasound picture of that kind of essentially solid looking like lesion, but you can see those little microcysts in what has been previously described as a honeycomb appearance.
Thank you, Dr. Park, for a very comprehensive answer and review of that question. We do have an attendee who asks, for the purpose of the boards, what are cyst size numbers to keep in mind, where observation would not be favored and further diagnostics may be necessary? Not in this case, but potential mucinous or IPMN.
Yeah, it's a good question. Personally, I don't think using a cyst size is a fair question. I would think that they would, what you should see is maybe a cyst size included, but other factors such as main duct dilation or the presence of a mural nodule in the context of pancreatitis that would sway or make it clear that this is something you should actually operate on versus survey. If you were really to come across a question where they said, oh, this is a 3.5 centimeter cyst or a 4.5 centimeter cyst, and there's no other factors, and they say, surgical resection, that's not really a fair question, is what I would say, because the data doesn't necessarily say clearly what it should be. So I don't think you'll see that question. You might get a cyst size number, but there'll be other question stem points that should lead you to one versus the other.
Agree. Hopefully it wouldn't be just a size that's the single determinant of the correct answer on the board. Can we move on to the next question? A 45-year-old man undergoes an upper endoscopy for further evaluation of reflux. At the time of his EGD, an abnormality is seen at his ampulla. No additional lesions are seen within the examined duodenum. Further evaluation with a side viewer reveals the abnormality noted in the image. Biopsies are obtained and return positive for adenoma without high-grade dysplasia. Labs reveal a total bilirubin of 1, alkaline phosphatase of 67, AST 15, ALT 18. An EUS examination confirms a 15 millimeter ampullary lesion without invasion of the muscularis propria, common bile duct, or pancreas duct. Next slide. The next best step in management is A, surveillance with side viewing exam in 1 year, B, transduodenal ampulectomy, C, endoscopic resection, D, no further intervention is required, or E, pancreaticoduodenectomy. We'll await some responses and then we'll discuss. On to the answers. A little bit of a split here between transduodenal ampulectomy, endoscopic resection, and pancreaticoduodenectomy. So if we can go back to the question, I'll discuss this one and we'll have input from our panelists as well. So we're in the territory here for the patient having an incidental sporadic ampullary adenoma. And one has to ask oneself when you address this question, what are we worried about in this setting? We have an adenomatous tissue, no high-grade dysplasia, but the concern is that this could progress to adenocarcinoma. Historically, some of the responses that were selected, so pancreaticoduodenectomy, transduodenal resection, were the mainstays of management. But now for an adenoma this size, which is under 4 centimeters, no evidence of invasion into the common bile duct, and seems well circumscribed. Endoscopic approach would be the first line approach for endoscopic resection of this lesion. And this patient doesn't have, according to the question, we don't know of other comorbidities such as a polyposis syndrome, but it's worthwhile noting that in polyposis syndrome, surveillance for these ampullary adenomas should be undertaken regularly because they can be managed very similarly, but need to be found and managed when they're smaller and more endoscopically resectable. Can we go through the answer choices now? Nobody selected answer A, which I think is appropriate. Surveillance wouldn't be the best step in this patient who's otherwise young and healthy and isn't otherwise high risk for resection. Transduodenal ampulectomy and pancreaticoduodenectomies, choices B and E, as I mentioned, historical approaches, but not the next best step or the first line management approach currently. An endoscopic resection would be the most appropriate with an ampulectomy. These are now more commonly performed, and although it's a high-risk procedure in terms of the rates of post-resection pancreatitis, it can be performed very safely and is not higher risk relative to surgery based on some smaller series that have been published. And then choice D, again, similar to choice A, we would want to have a next step in management. Any other thoughts from our panelists?
Yeah, sure. None of these answers is necessarily wrong, so I can see why there's such a big scatter. Endoscopic resection is the best option. Essentially, your thought process should be, is this a sporadic adenoma, or is it one in the setting of a polyposis syndrome? You secondly look at size. The larger the lesion, the more likely you're to lean towards surgery to get a complete en bloc resection. My personal threshold is 3 centimeters. I know people who have a threshold of as low as 2 centimeters to push the patient towards surgery. You also want to look at, see, is the intraduodenal bile duct involved beyond 1 centimeter or so? If so, again, you might lean towards surgery to get a deeper excision. But for this particular patient with a small lesion, no high-grade dysplasia, endoscopic resection is probably the best option. In the real world, there are a lot of people who actually choose the first option, surveillance. I know I'm following at least 4 patients who, having heard the risk of complications with both endoscopic resection and with surgery, have opted to go with surveillance. It's not a small complication rate. In most series, it's upwards of 15%. The commonest complications being, of course, pancreatitis, bleeding, perforation, recurrence of the adenoma, especially in polyposis syndromes, where you might lean towards surgery. And so that complication rate, there are patients who opt, if they don't have high-grade dysplasia, to undergo surveillance endoscopy every 6 to 12 months and with biopsies, with the understanding that if they ever find high-grade dysplasia, they will agree to undergo resection. Surgery, like I say, is best in very large lesions where you have evidence of intramucosal cancers or deeper cancers on your biopsies. And sometimes in the setting of FAP, where there's marked duodenal polyposis as well, it makes sense in that situation to just get a pancreatic or duodenectomy and get all these polyps out in one go. So that's an option to consider for the FAP polyposis patients. Samir, your thoughts? Or,
Totally agree. I think the key in these lesions is to evaluate them correctly for being a benign stage of the disease, and make sure that they're not involving beyond 1 centimeter of the bile duct or pancreatic duct. So endoscopic ultrasound and endoscopy are essential in this evaluation. The cutoff of 3 centimeter, 4 centimeter as a green light to do endoscopic resection has been challenged with some case series where lesions that are larger have been removed. So there's no evidence of malignancy based on the endoscopic evaluation. They can't be treated like large colonic polyp or large duodenal polyp. The technique will be a little bit a variant technique where you remove the center of it as you do for empulectomy, and then you continue the rest by doing EMR, by lifting and cutting in piecemeal. The reason for that is because Whipple surgery is not a simple surgery. It's very complicated, associated with high morbidity and mortality. So if that can be achieved endoscopically, is probably the best approach. But the patient has to be aware, and the physician has to be aware of the potential complications. You want to remove the lesion. The recurrence rate might be higher when it is large, and you have to make sure that you are stenting the pancreatic duct and the bile duct after during the procedure to decrease the chance of scarring, obstruction, and the most feared complication is post anaphylactic pancreatitis. Beside perforation and bleeding, but severe pancreatitis is the concern. So stenting with a little bit longer stents, not just the regular prophylactic stenting, is the way to go when you ensure access to the pancreatic duct.
And indomethacin, of course.
Yes, certainly. Thank you for those discussions. That's really important. We have a question from an attendee. Are there circumstances in which a colonoscopy might be recommended in this 45-year-old man with ampullary adenoma? So by current colonoscopy for screening guidelines, it would be reasonable to perform a colonoscopy in this patient by his age alone. But unless I think this question is getting at whether we'd be concerned about a polyposis syndrome. And if there's no family history of a polyposis syndrome, no bleeding for this patient, no rectal bleeding, I would take a very detailed history about all of that. And if there are no other polyps seen in the duodenum, this finding alone of a sporadic ampullary adenoma would not trigger a workup for a polyposis syndrome. Other thoughts from attendees? Panelists?
Okay.
Okay. All right, we'll move on to the next question. 42-year-old woman with a history of prior cholecystectomy presents to your clinic for further evaluation of episodic right upper quadrant pain, which lasts 30 minutes to 1 hour and occurs every month. She's also had an intermittent rise in her AST and ALT 2 times the upper limit of normal on 2 separate occasions over the last 6 months. Imaging, including ultrasound and MRCP, has been performed and has shown a 4-millimeter bile duct without a filling defect. Her symptoms are felt to be consistent with functional biliary sphincter of Oddi disorder, type 2 sphincter of Oddi dysfunction. She undergoes an ERCP with manometry. Her manometry does not show basal biliary sphincter's pressure measurements greater than 40 millimeters mercury. The upper limit of normal for basal biliary sphincter pressure is 40. Based upon the manometry results, you should A, perform a biliary sphincterotomy, B, perform a pancreatic sphincterotomy, C, perform both biliary and pancreatic sphincterotomy, D, place a biliary stent without sphincterotomy, E, not perform a sphincterotomy. So we'll get our responses and then we'll discuss the question. Okay, can we move on to see responses? Okay, 83% said not perform a sphincterotomy and 71 and 29% perform a sphincterotomy or not perform a sphincterotomy. Dr. Eldika, would you perform a sphincterotomy?
No, and the reason for that, so this is sphincter of Oddi dysfunction, which is a very controversial topic. It's related to spasm of the ampulla of Vater or stenosis. Reason is unclear. It's mostly described after cholecystectomy. It's divided into different types: type 1, type 2, and type 3. Type 1, when you have biliary type pain plus dilated bile duct and elevated transaminases, usually more than 2 times upper limit of normal. So in the absence of other reasons, for type 1, where you have all the 3 criteria, then doing a biliary sphincterotomy is the way to go, and usually the patient responds to that in more than 90% of the time. Now in type 2, like in this case, where you have biliary type pain, elevated LFTs, but no dilated biliary tree, you can't just go ahead and do biliary sphincterotomy or pancreatic sphincterotomy. We can talk about that. And you need to do manometry to make sure that the major papillar pressure is the ampullary pressure is more than 40. If it is more than 40, then in type 2 you can go ahead and do a sphincterotomy. If it's not, then patients would not respond. So if it's positive, the response can be up to 70%. If it's not, they're not going to respond. So you should avoid it and avoid the patient from, potential of getting pancreatitis with this intervention, especially, in a lady and non-dilated biliary tree. Type 3 is when you just have biliary type pain without the other 2 features. And there are, studies have shown that intervention in these patients won't help. Endoscopic intervention with sphincterotomy won't help. So these patients are usually managed by pain managements and referral to, there's association with IBS and other functional GI disorders for that. So the answer for this type 2 is not to perform a sphincterotomy. And just manage as if this patient has type 3 sphincter dysfunction.
Thank you, Dr. Aldika. A question from attendee: is there any role for HIDA scan for sphincter avoidi dysfunction?
Yes. So there is in the literature, if you don't have like manometry measurement, there is data, radiologic data showing that if you have a positive HIDA scan where you, over time, you don't have release of the tracer from the bile duct, and if it's positive, then that's suggestive of sphincter avoidi dysfunction. And in this case, if it's a type 2, then the patient might benefit from sphincterotomy. If it's a type 1, then you don't need really to do any more testing. You just go ahead and do sphincterotomy. Now, do you do biliary or pancreas sphincterotomy for these cases? There's a randomized controlled trials from Indiana that have not shown that there's difference if you add pancreas sphincterotomy to biliary sphincterotomy. So you just limit it to biliary sphincterotomy.
Thank you. Any other comments from panelists?
No, I think Samir summed it up nicely. Basically, type 1, we always do sphincterotomy. Type 3, we never do sphincterotomy. So type 2 is the Goldilocks median, where the middle, which has all the controversy swirling around it. And I honestly sympathize with the participants who chose A, because there are a lot of experts who just do that, right? They don't bother with manometry. As long as the patient has shown spikes in liver function tests, they will cut. But there's not a lot of evidence to support that. Equally, is there a lot of evidence to support not performing a sphincterotomy in somebody with normal pressures? The answer is just a couple of trials, and both very small trials and double-digit figures. But that's, it's bad evidence, but that's the only evidence we have to say if the pressures are normal, don't cut.
Thank you. That's certainly a controversial topic. Next slide, we'll go on to our next question. A 57-year-old female presents with intermittent abdominal pain, heartburn, and nausea. The patient also reports diarrhea, up to 3 to 4 loose bowel movements per day. An upper endoscopy reveals esophagitis, antral erythema with erosions, and multiple small ulcerations in the duodenum. Small bowel biopsies show inflammation with mild villus atrophy. Celiac spruce serology and gastric biopsies are unremarkable. The above clinical symptoms are most consistent with which of the following neuroendocrine tumors? A, gastrinoma, B, glucagonoma, C, insulinoma, D, VIPoma, or E, somatostatinoma. We'll await responses and then discuss the question. Okay, can we see responses? Okay, the vast majority chose gastrinoma, with a subset choosing VIPoma. Dr. Park, would you like to walk us through this question?
Yeah, this is your classic boards question of what do you remember of, rare kind of syndrome diseases like biliary cysts and stuff. But it gets back to what's in the question and what's not in the question stem, right? So, and part of it just goes back to what do you recall the cardinal hallmark features of each of these functioning neuroendocrine tumors? And if we go back to the question, gastrinoma is strongly suggested by the ulcer disease, the esophagitis, the erythema, in the context of this diarrhea, which is why it would be appropriate to think gastrinoma. Could it be some of these others? Of course, in clinical practice, it could, but remember, in a boards review question setting, they have to be fairly clear. If it's vague, then it's not going to make it as a question. And so what's not in here? Well, if this is a glucagonoma, you'd expect them to be like high glucose levels. Insulinoma, the opposite. VIPoma, maybe some flushing. Somatostatinoma, probably constipation instead of diarrhea. So I think that's perhaps why gastrinoma here is perhaps the most appropriate and, in this case, correct answer. So they're giving you the positive features of gastrinoma and specifically not including the other cardinal features of the other symptoms. So A is the correct answer.
Thank you, Dr. Park. Let's move on to the next question. A 24-year-old man with ulcerative colitis in remission on vedolizumab presents with acute pancreatitis. Labs reveal a lipase of 875, AST 35, ALT 45, total bilirubin 2.5, alkaline phosphatase 200, white blood cell count of 9. CT scan reveals a mass in the pancreatic head with mild biliary and pancreatic ductal dilation. EUSFNA reveals a granulocytic epithelial lesion without any evidence of malignancy. What is the next step in the management of this patient? A, Whipple procedure, B, PET CT scan, C, laparoscopy, D, initiation of glucocorticoids, E, switch to infliximab. We'll await responses and then discuss the question. Okay, can we see the responses? The majority would initiate glucocorticoids, a subset would perform a PET CT scan, and a smaller subset switch to infliximab. Dr. Aldika, would you mind walking us through your logic for this question?
Sure. So pancreatic head mass in a young patient with biliary obstruction, you always have to think about malignancy in these patients. So that's the first thing you need to do. At this age, unlikely a pancreatic adenocarcinoma, but still patients can get other type of neoplasia, like carcinoid, which can cause biliary obstruction and pancreatic obstruction. PET CT scan can be done, but I don't know if it's going to add anything to the management. It is done like in Japan, patients who is thought to have autoimmune pancreatitis, looking at IgG4 related disease and inflammation in other parts of the body, but not in this case. Laparoscopy is not the answer for this case. I think the key finding is the EUS biopsy in this patient and the young age of this patient. They mentioned EUS FNA. I think this is kind of inadequate description of the intervention. It is a biopsy, it's not an FNA. So using a biopsy needle for that. And taking the specimen, putting it, if you're suspecting autoimmune pancreatitis, putting it in formalin so we don't get autolysis. And then these gel lesions, the granulocyte under the epithelial cells of the ducts are typical of type 2 autoimmune pancreatitis. So correct answer is D. Switch to infliximab is not the right answer because patient is really responding to vedolizumab, and his UC is in remission with that. So this is a type 2 autoimmune pancreatitis, duct-centric pancreatitis. I think I have a slide after this that summarize difference between the type 1 and type 2. Oh, this is large.
Well, we could have participants perhaps review it after.
Okay. I
the
mean, I
presentation.
can go through it. It's with type 1, it's part of a systemic disease, IgG4 related disease. Can involve the pancreas and other organs of the body, compared to in type 2, which also called idiopathic duct-centric pancreatitis. It's involving specifically the pancreas without involvement of the other organs. Typical histologic feature in type 1, lymphoplasmacytic infiltration, spleniform fibrosis, and phlebitis, along with IgG4 stained plasma cells. You can see some of these features in type 2, but not much of IgG4 stained plasma cells and the typical granulocytic epithelial lesion on the biopsy that are typical for that. Serum IgG4 elevated in about 70% of type 1. Not all the cases have elevated serum IgG4. However, they're not elevated in patients with type 2. Type 1 involve usually older patients and more males compared to younger patients and equal male to females for type 2. Type 2 is usually associated with inflammatory bowel disease, can be associated with inflammatory bowel disease, like in the case in the question.
Thank you for reviewing this, Dr. Eldika. Let's move on to our next question. Okay, a 40-year-old woman presents to the emergency department for further evaluation of right upper quadrant pain. She's noted to be febrile to 39 Celsius, hypotensive with a blood pressure of 80/40, and tachycardic with a heart rate of 120. Initial labs reveal a bilirubin of 6, alkaline phosphatase 250, AST 500, ALT 430, and a lipase of 1500. A right upper quadrant ultrasound shows a dilated bile duct to 11 millimeters with an 8 millimeter hyperechoic focus within the common bile duct, as well as several hyperechoic foci within the gallbladder. She is stabilized and undergoes ERCP with stone extraction. She does well post-procedure. What is her risk of a recurrent biliary event if she does not undergo cholecystectomy? A, 0 to 10, B, 20 to 40, C, 50 to 70, or D, 80 to 100%. We'll await responses and then discuss the question. Okay, can we see a response? Okay, we have quite a split here. And this is, again, kind of a you know it or you don't type of question. First, to step back to the question itself, we're discussing recurrent biliary events. Recurrent biliary event thought to be recurrent obstructive biliary event, cholangitis, biliary colic, recurrent gallstone pancreatitis. Any of those would qualify. The thought is we cleared a stone from the duct during ERCP, and what is the risk that another stone will drop into the duct, cause recurrent obstruction? There's more robust and increasingly robust literature here to suggest that between about 18 and 40% of patients who have an event undergo ERCP and don't undergo cholecystectomy during that index admission will develop a recurrent biliary event. And there's no formal guideline here, but work from our group and others has demonstrated that there is increased risk if patients don't undergo cholecystectomy during that index admission, or in the case of severe pancreatitis, when a surgeon might consider the patient's higher risk for cholecystectomy and prefer to wait about 6 weeks within a timely manner. Up to 50% of patients who have biliary events, even undergo ERCP, don't get their cholecystectomy in this timely manner, and that really does increase risk to the patient. So it's nice that this question is included here and that it's acknowledged that this is a very significant clinical issue for pancreatic biliary care of our patients. And again, so the correct answer would be B, 20 to 40%. And this is just kind of an evidence-based recognition question. Other comments from panelists? We do have a slide on this as well. And this slide, if we can just shrink it a little bit, just discusses to some extent what I was sharing in that urgent ERCP urgent being defined as within about 48 hours in the setting of biliary pancreatitis, cholangitis, and persistent obstruction is important. And I would separate those from pancreatitis and cholangitis. Cholangitis being if there's obstruction, one should get an urgent ERCP. For biliary pancreatitis, one would want to see a stone or an obstruction or meet criteria to get an ERCP, because that is a bit higher risk for exacerbating the pancreatitis in these patients. And that's getting to the second bullet point that it should be avoided if there's no evidence of obstruction, and it being the ERCP. In patients with mild biliary pancreatitis, during index hospitalization, cholecystectomy can often be safely performed and can prevent readmission and complications for the patient. And then for moderately severe to severe biliary pancreatitis, waiting 6 weeks is often recommended. Although we find that our surgeons are often comfortable performing a cholecystectomy during the admission in these patients as well. So it's reasonable to consider during the initial index hospitalization for all patients. Okay, move on to our next question. A 52-year-old man is referred in order to evaluate an incidental finding detected on a CT scan. Recently, he underwent a CT of his abdomen during an evaluation for hematuria. This showed a cystic structure on the medial wall of the duodenum. You perform an ERCP, shown below, which reveals a focal dilation of the intraduodenal portion of the bile duct. Which of the following is the correct diagnosis? A, type 1 biliary cyst, B, type 2 biliary cyst, C, type 3 biliary cyst, D, type 4A biliary cyst, E, type 4B biliary cyst. We'll wait a few seconds for responses and then move on to discussion. Okay, can we see the answers? We have a split between type 3 and type 4A biliary cyst. Dr. Banerjee, would you like to discuss this question?
Sure, of course. It's extension of the first question I dealt with. Can we go back to that cholangiogram, the previous slide? So the tip of that, the correct answer is a type 3 cyst is based on this cholangiogram, which shows a relatively normal bile duct in the upper part of the cholangiogram. I don't have an arrow to point at, but then in the bottom third, you see this area of narrowing, which is the intrasphincteric bile duct. And then more distally, you can see the air in the duodenum and this bulging contrast-filled sac in the duodenum. And I think those are the clues in the cholangiogram to tip you off that this is a type 3 cyst. We've discussed all the different kinds already, so I won't go into that again. Key things with the type 3 cyst is that they're rare, probably less than 5% of all cysts are type 3 biliary cysts. The commonest, again, is the type 1, which is about anywhere from 50 to 80% in most series. Type 2 and 3 are both rare, under 5% for both of these. And type 4 and 5 are roughly in the ballpark of 20% of most cyst series. So again, first thing is it's uncommon. Secondly is it's the only type that can be completely managed endoscopically with the big sphincterotomy, possibly endoscopic resection. Third thing, the risk of malignancy is much lower, just to reinforce that, with type 2 and type 3. Much, much higher in type 1, type 4, and type 5. Type 1 and type 4, therefore, are treated with excision of the bile duct to decrease cancer risk because it's so low. And type 2 can be resected easily. Type 3, the risk is so low, low single digits, that we don't usually recommend much more beyond endoscopic excision. Within the cyst, there have been two kinds of lining reported, biliary epithelium or intestinal type epithelium. And it's thought that, again, based on very small series, it's thought that those with bile duct epithelium may be at a slightly higher risk of cancer. But again, very endoscopically manageable, low cancer risk. And the key is it's all the cystic structures within the duodenum very visible, both in cholangiograms and endoscopically.
Thank you, Dr. Banerjee, for continuing education regarding biliary cysts. We'll move on to the next question. 72-year-old woman presents to established care after recently moving from Central America. She does note abdominal fullness and early satiety. She is otherwise healthy. On physical examination, her abdomen is distended with a palpable mass in the upper abdomen. Her laboratory evaluation is as follows: total bilirubin 1.1, direct bilirubin 0.4, alkaline phosphatase 120, ALT 41, AST 33, CA 19.9, 315. You recommend MRI of the abdomen, which is shown below. She subsequently undergoes a surgical resection of the lesion. The pathology shows that the structure has a layer of cuboidal cells with underlying ovarian-type stroma. What is the most likely diagnosis? A, intrahepatic cholangiocarcinoma, B, echinococcal cyst, C, type 1 biliary cyst, D, biliary cystadenoma, or E, type 2 biliary cyst. We'll wait response. Okay, can we see responses? Okay, so biliary cystadenoma or echinococcal cyst. As this is the last question in our session, I'm going to open this one up to each panelist to comment as they like.
I guess I'll just go first. I mean, the way I think about it, about this question, you look at the image, and in this case, they did pathology. And I think the key word here, the key question is correlating ovarian type stroma. And you see that the pancreas version is the mucinous cystadenoma. And similarly here, you have the biliary cystadenoma. So I think that's where you kind of cue in. I think the echinococcal cyst can be kind of a red herring, but and can throw you off with the immigrant from Central America with this large kind of cystic lesion, but you don't see any other further evidence for that. And in favor of the cystadenoma, you see the ovarian type stroma.
Thank you, Dr. Park. Any other comments from panelists? Any questions from our attendees?
I think the only thing else to note is that the nomenclature may be changing. A lot of people are now referring to these as just mucinous cystic neoplasms of the liver. So be aware of that, because that may be the choice rather than biliary cystadenoma in the coming year or future years.
And type 1 and type 2 biliary cysts are extrahepatic. They're not intrahepatic like in this case. So these are wrong answers because of that.
Great. Well, thank you to each of the panelists, to all of our attendees. This concludes our pancreaticobiliary session, close to on time.
Yes, thank you so much to all our panelists. It was a very robust discussion. We will now take about a little more than a 15-minute break. The next session will be liver disease, starting at 9:55.
Thank you.
Good morning, everyone. Welcome again to the second day of our 2021 Gastroenterology and Hepatology Board Review course. Today's course is going to be focused on pancreatic and biliary disorders, followed by liver disease. And these two categories will comprise 30% of your board course. This is our disclosure slide, as well as